the conference in person today, but I'm honored to be asked to present on a topic I'm very passionate about, which is anticoagulation and ECMO. Today we'll be discussing how we have navigated the unknowns when it comes to anticoagulating our patients who require ECMO and who have COVID. I have nothing to disclose and have no conflicts of interest in regards to this talk. Before we start, I want to make sure to establish a scope for this presentation, since there's a lot of varying approaches to how to address anticoagulation in ECMO. And so for this talk, I'm going to be focusing on the adult population. Personally, I have very little experience with pediatric ECMO, but what I do know is that the anticoagulation monitoring, dosing, and response can vary greatly between adults and children. And so we're really unable to extrapolate data from adults to children or vice versa. So this talk will focus on adults. We'll be focusing on VV ECMO, since that's the most common modality used in patients who are actively infected with COVID. Then I want to make sure to reiterate or establish the fact that anticoagulation in ECMO has evolved drastically over the years and is quite dynamic. And I think we can all appreciate how dynamic the management of COVID has been over the past 2 years. So the information I'm including within this presentation is up to date as of 5/20 of the year 2022. And it's very plausible that between the time I'm recording this presentation and the time you guys are all listening to it, that new information could come out. I wouldn't doubt if that were the case. So we'll be walking through some of the data up to this date. So I'm going to spare you the long drawn out background of COVID, since we've all lived it for the past 2.5 years. But for the purpose of this presentation, I want to make sure we touch on kind of the background in relation to COVID, thrombosis, and the use of ECMO. COVID obviously has been a key contributor to severe ARDS over the past 2.5 years. But aside from that lung pathology, we've also realized that it's associated with thromboembolic disease, which has been coined COVID-19 associated coagulopathy. What is interesting about COVID coagulopathy is that it differs from other prothrombotic states, which are often some prothrombotic instigator in areas of stagnant blood flow that lead to clot formation and ultimate embolization if left untreated. COVID differs a little bit in the fact that it is thought to be more inflammation driven, along with a pan-endotheliitis. And so what has been recognized in patients with COVID is it's more common now to see in situ thrombosis in large or small arteries or veins. So rather than an embolism happening, it's vessel damage and inflammation that leads to clot formation at that specific site, which can certainly still embolize more distally, but still different from what we're used to with clot formation with other diseases. Another aspect of this clot formation is when it occurs in the capillary-alveolar interface, it may also contribute further to the respiratory that we see alongside with the ARDS. Early observational studies, when this was recognized, there was early observational studies that looked at patients who received anticoagulation versus those who didn't in a non-randomized, more observational fashion, and found that patients who received anticoagulation had a higher incidence of freedom from intubation and better survival in those who are hospitalized. And so very early on, prophylactic level heparin became a de facto standard of care as long as the patient did not have contraindications. Today, to this date, the ideal intensive anticoagulation continues to be explored, and we'll talk about a little bit that specifically in our critical populations. When the ARDS is severe enough, ECMO has been recommended in selected patients who are refractory to optimal ventilator management and prone positioning. And so really we're left with a patient population who's supported by ECMO and who may have some prothrombotic. Now, if you look at ECMO in general, aside from COVID, it is a really delicate balance between hypercoagulability and hypocoagulability, so bleeding and thrombotic risk. And you can look at this in the context of the ECMO support itself, pre-existing patient conditions that may contribute to bleeding or thrombosis, and then other therapies that we're providing to the patients that may fall on one side of the spectrum or not. So it's very, very complicated and a very delicate balance. In anticoagulation really plays a central role in assuring that we optimize the efficacy and minimize the risk. But then you drop COVID in the middle of this, and it really makes it all that much more complicated. So anytime we're talking about anticoagulation and ECMO, there's the three clinical questions, which is which medication or anticoagulant should we use? How should we monitor that anticoagulant, and at what intensity we should use it? And this will really provide the framework for our discussion going forward. ELSO came out with guidelines on COVID and ECMO back in May of 2021. And in the anticoagulation section of that guideline, while they address the fact that COVID-19 certainly has a coagulopathy associated with it, that there really is insufficient data to suggest a deviation from usual anticoagulation practices in ECMO. Now, if you move on to the anticoagulation guidelines that were provided by ELSO a couple months prior, again, looking at agent selection, monitoring, and anticoagulation intensity, they really don't give concrete recommendations on the use of heparin over alternatives, exactly how to monitor the anticoagulant of choice, and at what intensity to provide that anticoagulation. And it's at no fault to ELSO. The reality is that there is not definitive evidence out there, and if you're going to make a guideline, you have to have at least some level of strength and evidence to provide these recommendations, and really it doesn't exist. There's certainly literature out there, and we'll walk through some of that literature throughout this presentation that help guide how we approach anticoagulation for patients on ECMO with COVID. But there is no definitive guidance on this aspect of care. So hence my title, Navigating the Unknowns of Anticoagulation, COVID and ECMO, because there is a lot unknown for this clinical scenario. Rather than stopping the presentation here and having it be one of the most useless presentations you've ever experienced, I'm going to move forward and really walk through our approach to how we manage anticoagulation in COVID patients on ECMO, and then provide the rationale for why we did what we did, just to give you guys kind of a perspective of how we approached it and the rationale behind it, and you guys can take home what you will with how you'd like to apply this in your patients. So just to start, this is our anticoagulation guideline, or our kind of standard of how we address anticoagulation. So we remain a heparin first hospital, but certainly are confident in using bivalirudin in certain scenarios. And I'll dive deeper to each of these aspects as we move through the presentation. Our monitoring, we use Q6-hour APTT monitoring along with fairly regular heparin anti-10A monitoring. And we'll increase the frequency of that anti-10A monitoring if the APTT isn't providing or meeting our needs. And we'll consider ROTEM in situations of bleeding. As for anticoagulation intensity, our standard is a lower intensity protocol, which we define as a detectable level of heparin anticoagulation that falls below the therapeutic threshold. But we'll move to higher intensity, which is the low end of therapeutic for heparin as needed based off the clinical situation. So again, as we go through this presentation, we will get into more details and the rationale for why we chose this approach. So first, let's start out with agent. So I think there's two critical questions when we're selecting the anticoagulant of choice for this situation. Is there a specific anticoagulant that provides benefit over others in ECMO? And is there a specific anticoagulant that provides benefit over others in COVID? I think those are the two most critical questions for this. So let's start with, is there a specific anticoagulant that provides a benefit over others in ECMO? Parenteral unfractionated heparin has long been the standard of care in patients supported with ECMO, really up until recently. I would say in the past 5 to 10 years, there's been some interest in exploration in the use of parenteral direct thrombin inhibitors, specifically bivalirudin, and to some extent argatroban, as an alternative agent. The most commonly referenced rationale for this is a far more predictable response and potentially more stable dosing with the use of direct thrombin inhibitors, as well as less concern or no concern for heparin-induced thrombocytopenia, which would fall under this less non-bleeding ADR category. And so it's hard to argue that direct thrombin inhibitors don't do this better. You know, they are more predictable, they are more stable, and it takes HIT out of the equation. But for us, it doesn't mean that there isn't some value in heparin. And so where we see value in heparin is the opportunity for multimodal monitoring, which we'll talk about in next sections. Reversibility, there's no direct reversal agent for direct thrombin inhibitors, but we continue to have protamine as an option for heparin. And there's less end organ influence. When people reference the reversibility of heparin compared to direct thrombin inhibitors, often it's suggested that direct thrombin inhibitors, specifically bivalirudin, don't really need a reversal agent because of their short half-life, with bivalirudin being as low as 20 minutes. I think an important caveat to that is that 20 minutes is under normal renal function situations. And often in ECMO, our patients do not have normal renal function, therefore their half-life can actually be prolonged even longer than what we would see in heparin. So reversibility with a reversal agent certainly has value. The quick onset and offset, with the right protocols, I think we can attain a good onset and offset with heparin as well as direct thrombin inhibitors, so neutral on that front. Less bleeding risk. Some have extrapolated the less bleeding risk seen during PCI with direct thrombin inhibitors as compared to heparin, although I would argue that ECMO is a very different clinical situation, and there is really no drug interactions for either. So with these theoretical benefits for both sides, I've summarized here several studies. I looked back 5 years, so these are studies from the last 5 years, who had heparin compared to bivalirudin, and was not a before and after study. But what I mean by that is that all patients weren't started on heparin, and then some transitioned to bivalirudin or argatroban, and then the time on each agent studied, since I think those can be a little bit difficult to interpret. So what I came up here is 9 studies in the last 5 years. They're all observational, nothing prospective or randomized. But the outcomes are pretty consistently neutral, in my opinion. There are a couple studies out there that show a reduction in thrombosis and bleeding, and some that even show a reduction in mortality, but this has been no way been consistent across studies. And so my interpretation of this literature is bivalirudin or argatroban, although the majority of these studies were bivalirudin, is probably at least similar to heparin when it comes to the clinical outcomes that are we concerned with. And for me, the jury is still out on whether there is a potential for superiority. I do want to share that in the past couple of years, with our experiences with COVID, there have been some publications looking at bivalirudin and argatroban for VV ECMO in patients with COVID, and some comparisons. Some studies compares COVID, all of them were on direct thrombin inhibitors, but COVID versus non-COVID ARDS. The Bissell et al. Was just a large case series, just looking at overall bleeding and thrombosis rates. And then the Sattler study All patients start on unfractionated heparin, and then some were transitioned to direct thrombin inhibitor, and they looked at outcomes, bleeding and thrombosis outcomes based off the time spent on each agent, and saw that at least so far looks like our direct thrombin inhibitors are at least a viable alternative in COVID, but these by no means are, I would by no means call these practice-changing studies. So how about specific to COVID? Is there an agent or anticoagulant that provides benefit over others in COVID? So since we don't have agent-specific recommendations for drug selection in patients with COVID on ECMO, I do think we can turn to some other guidance that exists around critically ill patients with COVID not on ECMO. And so there's several organizations out there that have made recommendations related to thromboprophylaxis in the critically ill with COVID. And several of them single out unfractionated heparin and low molecular weight heparin as the agent of choice for thromboprophylaxis. There are some that say there's no direct evidence or don't really even make a statement on agent of choice, but specifically the NIH, ISTH, and CHEST suggests that heparin should be used for thromboprophylaxis. There's a few reasons why they delineated those agents. I think the primary one is experience. Early on, those observational studies early on that showed value in having a low level of anticoagulation on board in patients with COVID, they all used heparins in that scenario. And to date, there really is little to no comparisons with other parenteral anticoagulants. There are studies that are underway, but at this time, based off of experience, the a heparin product is the agent of choice. Now, we would not use low molecular weight heparin in patients with ECMO due to the potential for accumulation and renal dysfunction and the longer half-life. There's certainly value in having titratability. But the clinical experience thus far in critically ill patients with COVID suggests or is filled with mostly heparin. There's another aspect remains theoretical or hypothetical at this point, but raises some interesting points specific to heparins and what they may do off target aside from preventing clot formation. So some things that have been suggested through smaller studies is heparin may have direct antiviral effects specific to the spike protein in COVID. Heparin has anti-inflammatory properties that may blunt that inflammatory response that we think is part of the mediator of thrombosis generation by binding chemokines, cytokines, and complement factors and blocking nuclear transcriptase factor. And then there's some thought that heparin specifically may aid in endothelial function, specifically with reduction in leukocyte adhesion to endothelial cells, and may prevent that endotheliolitis that exists in patients who certainly have severe COVID. So while heparin remains our agent of choice as a first-line anticoagulant for ECMO in COVID, we certainly don't shy away from the use of bivalirudin if the clinical situation dictates. And so there's a number of scenarios where we'll absolutely or at least consider the use of bivalirudin. First off, the no-brainer is in patients with type 2 HIT. So heparin is contraindicated due to the thrombogenicity that can occur with heparin re-exposure. So we use the bivalirudin as our agent of choice, given its relatively short half-life, titratability, and the published clinical experience specifically with bival in ECMO. Aside from type 2 HIT, there's actually a type 1 HIT, which isn't thrombogenic in nature, but can still lead to thrombocytopenia. It's non-immune related. It's actually fairly prevalent, especially in the critical population, occurring in up to 30% of patients. And patients can see as high as a 30% drop in platelets. This is not seen with direct thrombin inhibitors. And so if someone is already thrombocytopenic for the many reasons a patient can, whether it be critically ill or the ECMO circuit itself or whatnot, if we can get back 30% of platelets to get them over, say, 50,000 or 60,000, by switching to bivalirudin, we will certainly do so if they don't carry any contraindications. We will freely use bivalirudin if a patient is experiencing true heparin resistance. Direct thrombin inhibitors overcome most mechanisms of resistance. And in the literature, specifically with ECMO, AT3 supplementation has not really shown to be consistently beneficial, probably due to the multiple different mechanisms that can lead to heparin resistance. But this can be overcome by direct thrombin inhibitors and is actually a more cost-effective way of doing so. So given our how comfortable we are with bivalirudin, we'll just make the switch if they do have heparin resistance. And then the more ambiguous situation is heparin failure. So if we're having either ongoing thrombosis or ongoing bleeding with heparin on board, and this is a reoccurring theme, in an effort to attempt to try something else, we'll make a consideration for a bivalirudin switch to see, I would say this most commonly comes up in bleeding scenarios, to see if for whatever reason that specific patient tolerates a direct thrombin inhibitor better. And we've had some success with that. So now to move on, we first talked about agent selection, and now next I'd like to talk about anticoagulant monitoring, and this will be specifically to heparin since that is our agent of choice. So also recommends a multimodal approach to anticoagulation monitoring, which I absolutely love. Each of these tests can tell us something a little bit different, and can be beneficial depending on how the patient is behaving on anticoagulation therapy. So I do think that there is a lot of value in following more than one monitoring parameter. I will say that at our institution, we do not routinely do ACTs other than at the time of cannulation. ACTs can be really highly variable, especially at the doses of heparin that get used during ECMO. Aside from larger boluses that are administered at the time of cannulation. So we do not routinely do that, although also recommends it. So when we talk about these different parameters, it's important to understand what can influence them and really their specificity to heparin. So ACT is by far and away the least specific to heparin when we're talking about ACT versus APTT versus heparin anti-10A. It is highly variable, and in the next slide we'll get into the specifics on what can influence that. APTT is kind of more in the middle of the road as compared to anti-10A. Anti-10A is going to be very specific to the heparin response, whereas the APTT will have some other influencing factors. I would say most notably coagulation factor deficiencies and liver dysfunction that may cause it to rise. But if you're looking for specifically what the heparin is doing, the heparin anti-10A is likely the gold standard out there. So as I mentioned, there's multiple factors that can influence the results of these monitoring tests, most notably with ACT and APTT, but also to a certain extent with unfractionated heparin anti-10A levels. Unfortunately, given the time restraints of the presentation, I could spend 30 minutes on this slide alone, but we don't have the time for that. So just what I want to make sure to point out or kind of orient you to this slide for your reference is that, again, there's a number of factors that can influence these tests outside of heparin itself. What is in blue in here can cause these factors to rise artificially, or disproportionately, I should say, not artificially, but disproportionately to the heparin dose. And the factors in gray can actually drive these tests down below what a true heparin response is. And then anything that is circled with a red box has an increased prevalence in patients with ECMO, and anything circled in a yellow box can have an increased prevalence in COVID. So you can just see how common these factors come into play when we have our patients who have COVID who are also on ECMO, and these considerations we need to have when we are interpreting these tests. So there have been comparisons with different monitoring parameters in patients on ECMO, specifically comparisons of APTT and anti-10A, and there's been some comparisons between ACTs and the test as well. The study I like to point out is from 2020, comparing APTTs and anti-10As. And so not surprisingly, the anti-10A had a better correlation with heparin dose as compared to APTTs, and that's to be expected. With anti-10As, mostly being affected by heparin, whereas more variables with the APTT. I think what's quite interesting is the fact that APTs were associated with more bleeding, while anti-10As were associated with less thrombosis. And I want to give a little bit of a thought on why APTTs might be associated with bleeding. One of the major primary reasons why we use APTT as our initial kind of scheduled monitoring parameter and then supplement with heparin levels. So if you have a patient with APTT monitoring, if a patient becomes coagulopathic on their own, whether they have a deficiency in fibrinogen, whether they have some liver dysfunction or some coagulation factor deficiencies, a coagulopathy will drive up the APTT, and which will subsequently drive down the heparin dose. Whereas with anti-10As, because it's not sensitive to any underlying coagulopathy, which can unfortunately be common in patients who are supported with ECMO, these patients receive the same heparin dose. And so I do think that there might be some value on the side of bleeding risk by using APTTs, whether it be scheduled like we do or whether it be at least spot checking them to make sure that we're appreciating any underlying coagulopathy that could be going on in that patient, and maybe adjusting the dose or the target levels of anticoagulation if that were to occur. I want to share this chart with you. I'll run through it briefly. So a very similar chart exists in the ELSO guidelines for anticoagulation, although their chart is with kind of a basis of heparin anti-10A monitoring and supplemental APTTs. I adapted that to if you were to go through scheduled APTT monitoring with supplemental anti-10As. And so anytime that we're monitoring multiple tests for anticoagulation, we have to have an idea of what we want to do or what's going on if those two results are discordant. And so you can see low target level or high for APTTs in blue, low target or high heparin anti-10A levels, and kind of what we would consider as an approach if with having these two separate results occurring. And so if both are low, it's pretty easy. You would increase the dose. If both are high, pretty easy, you increase the dose. Or both are at target range, again, easy because they're correlating, and you would maintain the same level of dosing. If we're continuously monitoring APTTs and then we find that our heparin anti-10As are high, we will actually move to anti-10A monitoring because out of concerns that there might be some suppressive factors that are occurring with APTT, specifically excess factor VIII, which we don't normally monitor, but has been well described in ECMO and in COVID. And so if those APTs are artificially suppressed and we believe the heparin anti-10A, we'll switch to that anti-10A monitoring. If our heparin anti-10As are low, but our APTTs are high, then we consider either reducing the dose of heparin or considering factor replacement, since the rationale for that discordance is probably most commonly an underlying coagulopathy that's occurring. And so we look further into whether this patient needs factor replacement, fibrinogen replacement, or just a reduction in heparin dosing depending on the clinical circumstance. I always let the patient, though, tell you how they're responding. And so, if someone's bleeding or clotting, and depending on the results, they're really how the patient's responding to the anticoagulant is probably most important. So we can get bogged down in these tests, but really the clinical response is one of the most important things that can continue to guide you. Monitoring goes beyond the anticoagulant itself. And so I was very happy to see also provide some recommendations on monitoring frequency and target levels for factors that are contribute to bleeding or thrombosis risk. but aren't necessarily the monitoring of the anticoagulant itself. We do not routinely check AT3s for the same reason in that we would not supplement AT3 and we would instead switch to direct thrombin inhibitors. But fibrinogen is independently associated with bleeding in ECMO. Elevated INR is independently associated with bleeding in ECMO. Platelet count hasn't really been established yet, but I'm hard pressed to believe that platelet count doesn't contribute to bleeding risk, especially when it's severely low. And so these are all reversible factors that can contribute to bleeding. And so we should be monitoring these and potentially correcting these, especially with someone with active bleeding, to allow us to our patients to tolerate the anticoagulation that they still unfortunately need due to biocompatibility with the ECMO circuit, oxygenator, and pump. So we've moved on from monitoring, and now finally I want to touch on intensity, which I'm going to have to go through kind of quickly time here. So going back to the same as agent selection, what intensity do we need for COVID? What intensity do we need? There's continued exploration on different heparin intensities for COVID. Unfortunately, we don't have data specific for ECMO, but we do have it for critically ill patients. And we had a very nice large landmark study published back in August of 2001 looking at critically ill patients with COVID and the exploration of going beyond prophylactic level of anticoagulation to therapeutic levels of anticoagulation. And the moral of the story is going to therapeutic did not provide any value in this critically ill population. Again, this is not specific to ECMO, but we don't have any other studies that would guide us in the ECMO realm. So at least from a COVID front, there does not appear to be an advantage beyond low levels of anticoagulation in regards to the COVID illness specific. So how about VV ECMO? Biocompatibility of the ECMO circuit is not perfect, but it certainly has improved over the years. And with that, it has been exploration on differing levels of anticoagulation and intensity in VV ECMO to see if we can get away with less while maintaining low thrombotic risk and improving the risk of bleeding associated with ECMO. Back in 2019, we had the HELP ECMO pilot trial, which was small, but it was actually prospective and randomized, which is a rarity with anticoagulation for ECMO. Pretty neutral response, although there was less transfusions required in the patients who were on lower levels of heparin. We had there's a single center study published in 2022 that was looking at 123 patients. And what they did was that over the years, their anticoagulation intensity had evolved, presumably based off of some of the outcomes that they were experiencing. And so they looked at outcomes over the years based off of the intensity of anticoagulation. What they found was that lower levels of APTT level guided anticoagulation seemed to reduce the risk of bleeding compared to some of the higher intensity protocols that they had historically, as well as red blood cell count transfusions. And with really neutral thrombotic outcome. There was another dual center study from 2021 that one center did a high intensity protocol, one center had a lower intensity protocol that found that with the lower intensity protocol, they did have more oxygenator changes at 15 days and a higher rate of thromboembolic events. So I think the important thing to point out here is really twofold. One is that these were two separate centers that could have been doing things that influenced the outcomes outside of anticoagulation. And there probably was more differences between the two centers than just the anticoagulation alone. The other piece I want to point out, though, is that the heparin dose in the low intensity protocol was very low on a per weight basis, lower than 500 units per hour. And so that's a very low level of anticoagulation, which really resulted in a very low level of APTTs. And so part of what I suspect is that maybe their level of anticoagulation for their low intensity was a little bit too low. But so while I'm kind of preaching that maybe we don't need full therapeutic anticoagulation, in patients on ECMO, we can't forget that there are patients who do require therapeutic anticoagulation, whether it be any pre-existing disease that they have or the thromboses that are occurring while. And so the therapeutic range of heparin is a heparin anti-10A or a correlated APDT that correlates to heparin anti-10A of 0.3 to 0.7. That's a pretty broad range for anticoagulation. And there was a study that was published back in 2021 where they looked at their heparin anti-10A levels and their bleeding events. And what they found is that the patients who bled, not surprisingly, had higher mean and max anti-10A levels, and that the inflection point of higher risk when they did a complex statistical analysis was that the inflection point for anti-10A bleeding risk was at 0.46, so kind of right at the middle of that therapeutic range of 0.3 to 0.7. And so, driver of why, with our intensity, we are very comfortable. If there's another indication for therapeutic anticoagulation, to use a detectable level of continuous infusion heparin that correlates to an anti-10A of 0.11 to 0.29. Most of our patients live in kind of that 0.2 range. But if we're going to move to a therapeutic level of anticoagulation, that we actually target the lower end of therapeutic range, so a 0.3 to 0.5, where you're still getting that therapeutic level to address their therapeutic needs, but not necessarily living on that higher end of therapeutic that may confer a bleeding risk based on the study that I just discussed.